Thank you very much. So it's my role to talk about whether we should indeed treat cryptogenic status epilepticus with immunomodulation as soon as it's diagnosed and give the evidence against this. These are my disclosures. So as I said, my answer to the question is resoundingly no. And for this, I'm going to give evidence with regards to, is there evidence that cryptogenic status epilepticus is autoimmune or immune-related, mediated in etiology? Does giving immunomodulatory therapy change outcome? There is the issue about even if we detect autoantibodies, and I will talk about whether we detect them at all, are they all pathogenic? And what about possible contraindications to immunomodulatory therapy in cryptogenic status epilepticus? So first of all, I'd accept my colleague has probably given some definitions, but some definitions with which to start so that we all know what we're talking about. Cryptogenic is a term that the International League Against Epilepsy and the classification of the epilepsies has tended to now change, recognizing that it is virtually equivalent to saying unknown cause, recognizing that some in the classification of status epilepticus, it is still utilized, but really it means an unknown cause. And when we're talking about this, the problem particularly is when we come to refractory status epilepticus. And we have new onset refractory status epilepticus, where a clinical presentation is not specific in a patient without active epilepsy or other pre-existing relevant neurological disorder, with new onset of refractory status epilepticus without a clear acute or active structural, toxic or metabolic cause. And what has tended to be included in this amongst the unknown is those with an autoimmune basis. And in children, a subcategory, febrile infection-related epilepsy syndrome. There's a prior febrile infection with fever starting between 2 weeks and 24 hours prior to the onset of refractory status epilepticus, with or without fever at the onset of the status epilepticus. And in view of the prior febrile infection, there has been some assumption that this is autoimmune in etiology. However, if we look at those where we found a definitive etiology in refractory status epilepticus, in this study, a retrospective review of 130 patients with no cause identified within 48 hours of admission, so subsequently determining whether there is a known cause, 52%, 67 out of 130, remained cryptogenic or unknown. There was indeed only 37% where a non-paraneoplastic autoimmune or a paraneoplastic condition was diagnosed as the cause of the refractory status epilepticus, so not the majority. And indeed, we have to bear in mind those that are related to infection, ultimately determined in 8%. And in children, here on the top, looking at new onset refractory status epilepticus and possible causes, maybe even less the result of autoimmune, with only 7.5% in this category amongst this cohort of status epilepticus. And again, looking in more detail at febrile or fires, here 77 cases of fires, only definitive autoantibodies only found in a small number, and indeed a very limited response to immunomodulatory therapy that has been given. So what about the use of immune therapies in view of the fact that certainly you could see whether there's any difference in outcome? Well, here, looking at predictors of outcome in the original study that I reported, 130 cases, looking at whether there was a good or a poor outcome was very significantly related to the number of complications that may have been seen as a result of the status epilepticus. There was no difference in outcome whether immune therapy was utilized, or indeed no difference in those that died or remained alive. Certainly, an abnormal CSF with pleocytosis or elevated protein levels was found in 73%. And one could argue that maybe there's evidence of inflammation, but not necessarily that it's immune mediated. I acknowledge that there are episodes of refractory status epilepticus that are the result of autoimmune or autoantibody disease. But there may be a slight difference between adults and children as to whether they present with status epilepticus. And you can see here in a study where they looked at NMDA receptor encephalitis and looked at children and adults, you can see that children may have presented with a seizure in around just under 50%, psychiatric change being very prevalent, and again, even more so in adults. Whereas if we're looking at status epilepticus, perhaps more of a likelihood in adults than indeed you see in children. There has been ongoing discussion about if we detect autoantibodies to neuronal cells or neuronal components, what relevance has this got to the disease, accepting the NMDA receptor encephalitis is a real entity, and those against voltage-gated potassium channel antibodies have very specific syndromes associated with that. But when the titers are not that high, are these really causative, or is it to do with the fact that this may be a biomarker of central nervous system disease? We know that and the other, to the contrast, of course, is why we're debating this, is that if we determine in autoimmune encephalitis or that autoantibodies are driving the disease, surely this could be treatable with immunotherapy and reduce the likelihood of morbidity in the longer term. However, we know that there are different forms of immunity. We have the innate immunity, which is probably what is driving the inflammation, and the adaptive immunity that is later onset, where we might determine autoimmune disease. And therefore, and also that there may be the occurrence of both pathological and physiological autoantibodies within the central nervous system. When it comes to treatment, is it going to be the same form of treatment to treat the adaptive immunity or the autoimmune disease, as you might see in whether we're treating the earlier adaptation or the inflammation? And the confusion perhaps also lies in studies of cohorts with established and newly diagnosed epilepsy, as seen here, looking at the detection of autoantibodies to one or more antigens, whether it be NMDA, GAD, or voltage-gated potassium channels. And you can see in this study that looked at a cohort of established epilepsy and a cohort of newly diagnosed epilepsy, 11% demonstrated autoantibodies to one or more antigens. Certainly this was more than would be seen in disease controls or healthy controls. And also, however, they were seen to be more prevalent in focal onset epilepsies of unknown etiology, rather than those that would have an etiology of another reason, such as structural metabolic. So there is some concern that a proportion of our focal onset epilepsies in a chronic state may be the result of autoimmune disease. But again, this is unknown. Is it really a marker of the establishment of the disease, or is it actually the driver of the disease? And as I've said, anti-inflammatory is not the same as immunomodulatory. Quite often we consider the use of steroids as perhaps suppressing an autoimmune reaction. But steroids are also anti-inflammatory. They are also utilised, particularly in children, as an anticonvulsant. So how much is the generic use of steroids really treating an underlying autoimmune disorder? And indeed, this study put forward the possible utilisation of an agent to combat inflammation rather than immunomodulation. anakinra, a recombinant version of the human IL-1 receptor antagonist, and certainly utilized in the case of fires in a child, appeared to lead to a degree of improvement utilized over 2 separate periods of time. And there have been anecdotal reports of further success since this initial report. And finally, refractory status epilepticus particularly, but status epilepticus, is not without its complications, as I've already mentioned, and this is related to, this can be the predictor of outcome, particularly the number of complications. More than one can predict poorer outcome. And you can see here, from the study of Gaspar and colleagues, looking at those 130 cases of refractory status, and looking at complications that occurred, and certainly those where the status epilepticus remained cryptogenic. There was some, although it was not significant, there was some impression that complications were more likely to occur. And when it comes to infection, that we may be concerned about if we start using immunosuppressive therapy particularly, you can see actually that respiratory infections, bloodstream infections, urinary tract infections were all infections that occurred, particularly, and if they were seen, particularly after status epilepticus was established, then they were also related to poor outcome. And surely if we blanketly give immunomodulatory therapy, then we may lower the susceptibility or increase the risk of these infections and maybe increase morbidity. So should cryptogenic status epilepticus be treated with immunomodulation as soon as it is diagnosed? I would still argue that we don't have any evidence to do this. In fact, there may be evidence that we could cause harm. Autoantibodies in cryptogenic status epilepticus, to those cell components that we know of, are detected in only a very small number of cases. There is no evidence that true immunomodulatory therapy influences outcome. I'm not arguing that we may not use anti-inflammatory therapy rather than immunomodulatory therapy, and this may indeed be safer in the longer term, particularly as there's a high morbidity associated with refractory status epilepticus. And this could, the use of immunosuppressive treatment could indeed lead to increased harm. Thank you.